Okay, so good afternoon, everyone. It's great being part of this FOAMed revolution, and thanks to @Cat Evans and the badEM crew for inviting me. It's indeed a privilege to be part of this exciting symposium today. I'm just so gutted that I missed the exciting lineup in front of me. Was it good? Yeah? All right, so I've got lots to live up to. The reason I wasn't here was because I'm on call. Cat, I have to give you my phone. If they do ring, just tell them they can't disturb me for the next 20 minutes. This is critical. They can call me back in 20 minutes. Oh, there we go. So hopefully my video works, and it should go in 3, 2, 1. Come on. Oh well, anyway, I did have some visuals of Mitchell's Plain Hospital. I spend most of my time there, apart from one day in the week where I work at Hedefeld Emergency Center. So while Craig tries to sort out this exciting video that I have, there we go. That's the place I work. It's a big Metro District hospital situated on the Cape Flats. I see some of my people in the house, so thank you for representing Mitchell's Plain. We're building a really great legacy at Mitchell's Plain Hospital. I think we have a fantastic group of emergency physicians, and we really want to be the powerhouse of emergency medicine, not only in Cape Town, but we want to lead the way. I administer a couple of Facebook pages. One is EMECG, which I administer together with some of my colleagues. The other one is Plain EM. So those of you on facial media, that's a good word though. Okay, social media, just look us up and like those pages. If any of you want to connect with me on Twitter, my Twitter handle is @Kamil Vallabh, and if you have any questions after this talk, you can mail me at the email address. All right, so I want to keep it really, really simple, and I'm going to try and achieve some of my objectives through a case that I was involved with recently. And some of the objectives I want to unpack is, what the is a LERTI? Maybe we should do our first poll now, Kat. I mean, green card, who knows what a LERTI is? Okay, right. Red card, those of you that have written LERTI in the last 72 hours. Confessions don't come easy, eh? All right. Also, through this case, I hope to get you to understand how to critically analyze and interpret data in the context of the patient's history and presentation. And most importantly, I want to focus on invalidating your assessment. Now, it need not seem to make sense that once you've made a diagnosis, you need to actually step back, look at your data, and actually try and think if everything actually makes sense. And then finally, we'll touch on some cognitive area and some strategies, how to employ or to use techniques to actually to try and eliminate cognitive error in the workplace. So this is the setting. Okay, we imagine yourself, yes, Randall, the unit doesn't look like this today. Don't worry, Team 4 has got it under control. So the unit's pumping. I mean, there's patients coming from everywhere. EMS is just rolling patients through the door. You can see patients are double parked in majors. And in comes a patient. Now, we all know that emergency medicine has the highest decision density, and no one can argue that, right? And I believe we only have a certain amount of cognitive bandwidth, right? It's that time of the afternoon, and you really don't want to see a sick patient come through the door. So this patient rolls in. She's a 36-year-old female. No background medical history. You quickly search through your electronic records, you can't find any history. She's come in extremely short of breath. And she's so short of breath that she can't actually provide you with a decent enough history. So you look at the patient report form. Doesn't really tell you much. I mean, you obviously can't read from there, but it basically says a lady looks sick, weak, foaming at the mouth, needs to come to hospital ASAP. Right? Destination, Mitchell's Plain, EC, where all good things go to. Right, so you've got your nurse in resus, and she's quickly attached some monitors and done some obs, and the first thing your eyes lock onto is SATs of 53%. So it's looking like this is a sick patient. You glance up at the monitors, and this is what you see. So running a tachy, 125. SATs are not looking so hot, 52%. Got a reasonable blood pressure, rest rate of 48. Okay, so gives you some time to actually do a quick focused examination. So the patient's altered, but she's arousable. You know, she can't really give you much of a history. She's muttering a few words. Extremely distressed. Really, really cool peripheries. She's got this pink frothy sputum, and you listen to her chest and you hear bilateral coarse crackles, but you're unable to hear any heart sounds. So in that time, you've called your trusted radiographers. They've come through to resus and they've done a bedside portable chest x-ray for you. So you have a quick glance at it, and you know what? You lock into your diagnosis. It has to be a Lurity, right? Okay, I mean, it looks like one. I mean, zebras are so uncommon. And you do an ECG because every single patient that rocks in to the unit gets an ECG, right? And after SARS talk, you know that every single patient must get an ECG. And you've got this nailed down. It's a sinus tachycardia. You know, it's a bit of a poor baseline because she's so short of breath. There's really, really nothing to it. And you move on. So you do a point of care ultrasound because you can and you have the skills. And CAT, you notice that the left ventricle is working. It's all kind of fitting in now, you know, hyperdynamic left ventricle. So it's all fitting in with sepsis. So you decide to do something. You give her some oxygen. You trial her on some 40% face mask oxygen. She's not really doing well. So then you put on to, you know, some higher FiO2 of oxygen in the form of a rebreather, and the SATs start to go up. You're thinking this is a Lurity, sepsis. Fluid is probably good for her, so you push a liter of crystalloid. You get the antibiotics in quickly because it's what you trained to do. You need to get on top of the sepsis, so you push ceftriaxone, right? Everyone gets that, right? It looks like a Lurity, right? It has to be a Lurity. And in the last month, we've seen 4 of these exactly like this. They've come in really, really sick, really short of breath. They've had x-rays that look like this, and you know what? They all ended up being Lurities. Right? So in the meantime, she's not really doing that well, so you decide to put up the NIV on her. You crank up the PEEP to about 10, and you see if you can improve her work of breathing. At the same time, you're able to do a point of care arterial blood gas, and you have a quick squeeze at it, and you notice that, you know, she's quite hypoxic. There's a huge AA gradient here. It must be all the pus in the lung. You know, she's starting to tire out. The CO2 is 9.1. The lactate is 7.3. She's got a bit of metabolic acidosis. It's fitting in. This has to be severe sepsis, right? Hyperlactatemia. X-ray looks like a Lurity. Okay, you've got this nailed down. Diagnosis sorted. Right? In the meantime, your labs have returned, and renal function's not looking too bad. Creates at 70, white cell counts 23. You've just validated that assessment. This has to be a Lurity, right? White cell counts up. I mean, what else is going to cause that? Okay, HIV negative, fortunately, and the troponin was done. I don't know why, but anyway, it's negative. Right. So this is what you do. You notice that she had some pink frothy sputum, so thinking maybe there's pulmonary edema, you know, could this be ARDS? So in a situation at the moment where we really don't have nitrocine in the country, all right, so the only thing we had at our disposal is sublingual isosorbate dinitrate, isotyl. So this woman is given 5 sublingual isotals, not all together, sort of like, you know, a few minutes apart. I'd be worried if given all together. And she's given 80 milligrams of furosemide IV, just to try and decrease those secretions, right? But she's really, really not tolerating the NIV. I mean, you know those patients, right? They agitated, they sweating, they really can't tolerate the mask. She's trying to rip it off. You getting the porters to hold down her arms, you asking for lorazepam, and you really want to sort out. So you decide to do a DSI, right? Correct call. She's not being sorted out. We really, really need to secure the airway before we can play anymore with this patient. So you give procedural sedation and the intubation goes off smoothly. You shove in a tube. Right. Shoved in your tube, done an X-ray, X-ray confirms tube is in the correct place, and infiltrates are getting worse. Right? But we know why that's happening, right? I mean, she's developing ARDS. You've seen 5 patients in the last couple of weeks that have developed ARDS rapidly. Okay? So, I mean, there's nothing that's just not abnormal about this case. It's to be expected. Okay, a few minutes later, you look up at the monitor, right? Patient's being ventilated, so there's, chest movement, but the patient's breathing down. You look at the rhythm strip, looks like a slow junctional rhythm. Can't pick up any SATs, BP is unrecordable. There's no end-tidal CO2. So you rapidly check for a central pulse. Patient doesn't have a pulse. So you start CPR, right? Because that's what we do when there's asystole, right? You do a few rounds of CPR, you give adrenaline twice, and there's ROSC after 10 minutes. Okay, and you start on an adrenaline drip. And you're thinking, okay, done relatively well here. I've avoided the clean kill. Almost. All right? She was sick. Right? She was sick. It was expected that she potentially was going to crash. Right? But we know it's a LRT. Right? And LRTs don't fool us. Okay? So let's step back and review this now. So we've made this diagnosis of a LRT. We think it's probably multi-lobar, right? Those chest X-ray findings are suggestive of it. And we think now it's progressed rapidly, right? It's complicated by ARDS. And we know it's severe sepsis, right? The lactate's through the roof. She's got a metabolic acidosis. We're on the right track. We know that she requires inotropes and ventilatory support. Okay, so we are seeing this, but are we really knowing what we're seeing? So we've kind of hitched onto a diagnosis. It's, we've anchored onto a diagnosis to be more technical. We've tried to confirm our diagnosis because we've made our test results look like it's going to fit a particular diagnosis. And this diagnosis has just got momentum, right? When she decompensated, we thought, you know what, she was just sick. And this is what LRTs do. They just become sicker. All right, so let's go back to our X-ray, right? And let's actually go through the process of invalidating our assessment. So what have we actually missed here? Right, so the cardiothoracic ratio is increased, and I know it is an AP mobile X-ray, so that's to be expected, but let's not deny that the cardiothoracic ratio is increased. It's got a straight left heart border. Did any of us actually see that on the first X-ray? There's no prize for that, by the way. Okay. It's got a splayed carina. Okay, it's almost approximating about 90 degrees. She's got an enlarged right pulmonary artery. And she's got some vascular pruning. All right, so now it's a bit more tricky. So it's not just looking like a LRT. Something else is going on here. And, are we actually missing something? So I'll go back to my ECG. Right? Let's have a look at it. So I agree, sinus tachycardia. What axis is it? Okay, you've got a 50%, okay, you've got a 33.333% of being right. Okay, it's right. All right? What's happening to the P wave there? P wave looks large, right? It's suggestive of right atrial enlargement. Okay? Look at our RS ratio in V1. Okay? It suggests right ventricular hypertrophy. So ECG is telling us something else, and I've always taught my students and registrars and medical officers, if the ECG is saying something else, always go back to the patient. Something is not right. So we've got an X-ray which is showing us potentially that the left atrium is big because the carina is splayed. It's showing us that there's pulmonary edema, there's, the cardiothoracic ratio is enlarged, maybe the right ventricle is enlarged. The ECG is incontrovertible. It's showing me a right axis. It's showing me that there's right atrial enlargement, and it's showing me that there's right ventricular enlargement. So am I missing something? So let's go back to our ultrasound point of care CAT. So I've slowed it down now, right? I've slowed it down. Okay, not so slow. Okay, let me move back, CAT. There. So I look at my ultrasound. Right, and I've just got a still image now. So what do I notice now? Okay, so my left atrium is enlarged, right? It shouldn't be that big. It's actually bigger than my outflow tract. Okay, my right ventricle is looking huge. And we know that the RV should be about 60% of the size of the LV, right? Notice that there's mitral stenosis, and that mitral valve is just not opening. And I notice this strange hockey stick configuration of the tips of the mitral valve. In addition, I noticed that that left ventricle is actually being pressed in by the right ventricle. In fact, the right ventricle is so large that it's actually causing bowing in of my left ventricle. So what have I actually missed? So I'm treating this as a Lurti, but my data is telling me that I've got a patient with an enlarged left atrium. The mitral valve looks stenotic. The right ventricle looks huge. The right ventricle is so huge that it's actually impeding my left ventricular function. So what have we actually not seen? So we've not seen a tight mitral stenosis because we've been thinking this is a lower respiratory tract infection, right? We've been managing her with antibiotics, thinking that she's going to get better, when in fact we should have been managing her as a crashing pulmonary hypertension picture, right? I mean, everything is pointing towards pulmonary hypertension. What we needed to be doing was to optimize her right ventricular function. She almost died because we put her on positive pressure ventilation, we decreased her preload, we gave her isotal, we made her systemic vascular resistance even lower, and we almost enforced the clean kill. Right? This is what we needed to have been doing. We needed to make sure we had a decent SVR, and we needed to make sure that we decreased her pulmonary venous pressures. All right, so what didn't we see again? Right? We had enough knowledge, but our decision making wasn't spot on. We zoomed into a diagnosis, right? We anchored onto a diagnosis of a lower respiratory tract infection. And we made our test results fit our diagnosis, right? We had seen so many cases in the last few weeks, right? So it had to be a Lurti, right? And we didn't actually correlate our patient with the clinical signs and the data that was available to us. And from a clinical perspective, we completely ignored the right ventricle. All right, so just want to summarize with a few take-home points. Breathless patients and a crappy chest x-ray does not equal an LRTI, always. Right? What the is an LRTI anyway? Okay? Are you banned from ever using it anymore? All right? Right? The most important thing is to always combine and correlate your data with your clinical presentation. Right? As we become more facile with ultrasound, we need to be using it more and more, but we need to use it wisely. An idiot with an ultrasound probe is still an idiot. All right? Force yourself to cognitively de-bias, right? Ask yourself why things are not making sense. All right? Fortunately, we were able to pick up on our cognitive errors. Okay, we reviewed our details, we reviewed our data, we reviewed our case. We fortunately got the patient across to cardiology. It confirmed that she had severe mitral stenosis, and happy to say she had a surgery a couple of days later and she's doing well, being discharged. It's not a matter of knowing enough, right? So knowledge is not enough. It's the ability to use that knowledge to make good decisions. And we can only become better through failure. So it's okay if you make bad decisions as long as you learn and reflect on them, right? Ultimately, the aim is to provide better care for our patients because they deserve it. Thank you.